I would say, in a word, knowledge of Parkinson's disease has advanced exponentially. This is because multiple avenues of research have been opened and are open, ranging from underlying mechanisms, so diagnosis or etiology of Parkinson's, what causes it, and this obviously using a range of approaches from cells to animal models. Other avenues are more focused on management or treatment options in Parkinson's disease. Some of these are based on the findings from the underlying mechanisms research. Others are based on what we know. Parkinson's disease was first described more than 200 years ago. And so since then, we have had a long time to understand more and study it more from all points of view. And so we have come to a point where we know a lot, but there are still key questions. And these key questions have been receiving a lot of attention, as I say, from different perspectives. I think our understanding of Parkinson's has clearly improved, both from a biomolecular point of view, so understanding the molecular mechanisms of Parkinson's, but also from a pragmatic point of view, from a patient-based point of view. We are a lot more aware of how there can be a mismatch between what we consider important in Parkinson's from a scientific point of view and what patients consider important for their condition in terms of what they would like to have sorted out and treated in their day-to-day routine. So a patient-centered approach is what we really try to achieve from a clinical point of view. So helping patients with what they feel are the real problems in their day-to-day routine and not what we think is important just from our point of view. So it's more of a holistic approach, I think. I like to think that we are trying to achieve with Parkinson's and our understanding of it. Well, so we've had a real game-changing medication for about 50 years now, which is levodopa, and this has, in a way, had such a long-ranging impact that it has been difficult to replicate a finding of such magnitude. However, we have made advances in managing the symptoms of Parkinson's as well. I would say certainly the so-called non-oral treatments have been developed and fine-tuned a lot in recent years. These include subcutaneous infusion of apomorphine, continuous infusion of a levodopa gel directly into the intestine through a PEG tube, and deep brain stimulation. These treatments also have been known, I would say, for several years, decades, but they have been fine-tuned and perfected. And so the main theme of treatment in Parkinson's is that of tailoring treatment to the needs, the individual needs of the patient, because no two people with Parkinson's have the exact same clinical manifestation and evolution. So to help that tailoring process, we also have a range of other molecules that, in essence, all contribute to helping us maintain a stable dopaminergic tone in the striatum, in the brain, by affecting all of the enzymes involved in the pathway that involves dopamine, to keep that stable as much as possible. And we have many molecules for that. And there is a constant research to find new such molecules, often by repurposing medications from other fields or by developing new molecules testing them on cells, and then animal models, and then humans. Well, so to go back to the theme of different avenues, I think one of the important ones is to really try to get a grasp of why a very specific part of the brain and a very specific type of nerve cells is involved in the degeneration, why these cells die and not all of the others. And these are dopaminergic, dopamine producing cells in a very specific part of the brain. And even in that specific part of the brain, only a subtype of cells degenerates. And this is called selective vulnerability. And so one of the key questions is, why is there this selective vulnerability? Because finding that answer would allow us to start developing a very, very specific treatment. So a good deal of effort is aimed at that, at this concept of selective vulnerability. Another important avenue is to develop so-called disease-modifying treatment, in essence, a cure. Because what we have is symptomatic treatment, and it can be very effective for many years, and is fortunately very effective for many years, but it is not a cure. It doesn't change the natural progression of the condition. And so a lot of effort is aimed at obtaining this. And two of the important routes in this area are stem cell research. So finding ways in which we might one day be able to replace those cells that are lost. And in recent decades, scientists have become able to generate dopaminergic cells. And now really the trick would be to be able to get them to the part of the brain that we need to get them to, for them to replace those that have been lost. Another aspect of looking into disease-modifying treatment is based on immune therapy. We know that one of the driving causes of Parkinson's is the deposition in cells of aggregates of a misfolded protein called alpha-synuclein. And so if we were to be able to understand early on whether someone is going to develop Parkinson's, we might be able to stop that process of these cells precipitating in neurons and causing damage. And so there are ongoing trials looking into how antibodies that we can give the person involved that may target misfolded alpha-synuclein and prevent it from precipitating in the first place. Obviously, these are very ambitious goals, but there is a huge amount of scientific effort going into it. So we might be seeing some real changes soon. So these could lead to disease modification and ultimately a cure. That's a debated question, whether Parkinson's is increasing in incidence, or whether it might be explained, this apparent increase in prevalence rather of Parkinson's, by other factors. Certainly, we are an aging population, and the risk of Parkinson's increases with age. It is also true that in general, as a medical society, we have become more aware of this condition and more able to diagnose it, even when it presents in a slightly unusual way. There has been a lot of progress in our understanding of genetic forms of Parkinson's. So we are more able to find specific gene mutations that can cause Parkinsonian syndromes, and these can contribute to the overall impression of an increasing rate. I think the main driver of rising numbers of Parkinson's is attributable to an increasing age of the population. So I don't think there are new factors or risk factors for Parkinson's out there. I think the future of treatment for Parkinson's will be based mainly on the concept of tailoring treatment to the individual need of the person with Parkinson's. Um, there's a wide age range of people that can be affected by Parkinson's, and someone in their 50s or even their 40s or even their 30s will have very different needs to a person who is affected by Parkinson's, possibly in their 60s, 70s, or 80s. And now we do have a range of therapeutic options that can allow us to better tailor those needs. Also, I think we are going in a direction in which we need to study, implement non-pharmacological approaches to management of Parkinson's. One that surely stands out, I think, and should be encouraged and supported is exercise for Parkinson's disease, because increasingly we do have good evidence that this is beneficial on several fronts, not only to manage the symptoms of Parkinson's, but potentially even for long-term benefit through the years. And this is just one example of how we need to look at medications, but also beyond medications.